Suchi, are you also going to?
Including many of you. So I'm really honored to be here and to be part of this webinar series, and look forward to sharing some of our work with you. So the work I'm going to talk about today is primarily about the needs assessment that we did. This is a statewide needs assessment to understand how communities who are particularly vulnerable to COVID-19 have been dealing with the pandemic. And it was, the data was collected last summer, and the needs assessment was published in the fall, as you can see from the date at the bottom there. And it really was trying to lay the foundations for understanding how do we respond to the pandemic effectively in groups of people who we have good reason to worry may not have great access to the things that might make it easiest for them to prevent getting COVID-19 themselves or in their communities, and how do we respond when people do get COVID-19 as effectively as possible to protect health and lives. So we really wanted to sort of lay a foundation to be able to respond as well as possible at the state level and at the local level. And the foundations that I'm going to talk about today have been in use since then, all over the state through local organizations, some of which are run by people in this room, and also through local public health departments and state government. And I've also been working on the vaccination efforts through Ohio State University Wexner Medical Center, and really trying to apply some of these ideas about connecting with local communities that I'm about to talk about in order to help bring vaccination rates up as high as they can be, even among communities who may have a hard time accessing vaccines for one reason or another. So while my focus today is really on the statewide needs assessment, I would also be happy to talk about vaccination and vaccine equity as time allows, or if people have questions. So this is a quick overview of what I'm going to do today. I'm just going to give you a little introduction to Ohio's COVID-19 population needs assessment and help you understand kind of what we did in the needs assessment. And then I'm going to focus on the findings from our Asian and Asian American communities, which are one of 6 groups of communities that we really studied around the state, and talk a little bit about the work that we're doing on an ongoing basis and how you can access ongoing support from the needs assessment team if you have an idea or something you want to advance in that regard. So the needs assessment was born in the context of the Ohio Health Equity Work Group. So back at the very beginning of the pandemic, as things were just starting, it's early 2020, the director of health equity at the Ohio Department of Health, his name is Chip Allen, pulled together a work group to focus on COVID-19 and response and recovery from a health equity lens. And his idea was to bring together people who could provide insights about this problem, and then have those people work together to gather data, interpret data, collect data when necessary, when it didn't already exist, and use all those data to try to understand what do our populations need and how do we make sure that people get that. So this group included people from the Ohio Department of Health itself, from the Commission on Minority Health, from Ohio State's College of Public Health, which was myself and Dr. Juliana Nemeth, from the Kirwan Institute for the Study of Race and Ethnicity, and also from a consulting group that helped with quite a bit of data of certain kinds. So really the first thing that this group tried to do was to understand where are and who are the populations who are most at risk for COVID-19 disparities. And the idea here was that if we're going to try to provide particular supports to particular communities, where and with whom do we need to intervene? So there are 2 factors that predispose segments of Ohio's population to a high burden, higher than average burden of COVID-19 disease and death. The populations who are most vulnerable to death are people who have pre-existing medical conditions. This is why there was so much talk early in the pandemic about elderly people, because that's where pre-existing medical conditions are most likely to be, which puts people in a situation of potentially doing worse if they do get the virus. And then the populations who are most vulnerable to getting COVID-19 in the first place are populations who can't use the protections that would keep you from getting it, in particular, cannot socially distance due to the context in which they live and work. So really, this is about recognizing that not everyone is at equal risk. And there was a lot of analysis done to try to understand if we kind of think together about the populations who have the highest proportion of these residents who have underlying health conditions and the populations who have the lowest proportions of residents who can't socially distance, those are going to be the people who, the pockets of population and communities who will experience the highest burdens of COVID-19 disease and death. This was a very early analysis, but of course, the whole pandemic has borne this way of thinking out. What you see all the way there on the right is a map of Ohio, or kind of a snippet of one, just to give you an idea of how the group was thinking at the time. And basically the idea was, if we know these are the things that create a disproportionate risk of COVID-19 disease and death, then these are the places we really need to be worried about. These are the communities, the census tracts, the zip codes, where we're most likely to have people really suffering the most, and we need to put some attention there. So with that in mind, the next question was really, well, now that we know kind of where we need to look for the groups of people who maybe are most at risk, what are we going to do in those places? And at that point, it became clear that there really wasn't a lot of available data to help us understand what are these communities dealing with now, and how are they coping with the requests that have been made by the CDC about how everyone should go about protecting themselves against COVID-19. And so the idea was to understand, if we know where and kind of who we need to help, what do we need to do to help them, and how would we go about doing that? And this is the purpose of Ohio's COVID-19 population needs assessment, was to answer that question. And so basically we set out to identify the unique needs of diverse populations at risk for disparities by collecting data directly from community members and stakeholders. I know for sure that some of you participated in that effort at various points, and that was something we really appreciate. And then we published this needs assessment, which makes specific recommendations about how to implement CDC protections and what kinds of interventions need to take place to make that most accessible to everyone. There's a web link at the bottom left there. I'm also happy to send this around, or somebody might like to post it in the chat while I'm talking. If you're interested in this report that I'm talking about, it is important to note that it is available publicly online. We published it that way as fast as we possibly could to make sure that every organization, community, health agency who wanted to use these results would have access to them immediately. So it's available online. It's all in PDF form. It is quite a long report, but it's also divvied up in ways I'm about to show you to make it easy to access for whatever it is that you're trying to do. And I'll show that website again later. So basically, there's a underlying realization here, which is that not everybody has access to or will benefit from evidence-based interventions. Just because we know how to prevent people from getting a virus doesn't mean that we can actually effectively do that for all groups of people equally. So telling people, for instance, stay at least 6 feet away from anybody you don't live with is more doable for some people than others. For instance, if you are in the position, let's say, of being a professor who lives with 2 other people, in a single family home and can continue to do my work from home. I mean, I relocated it from my office to my home, but basically my work went on unimpeded as long as I didn't lose my internet access. I was able to kind of continue to do my job. So for me, taking the advice of staying 6 feet away from people I don't live with was doable. For other people, not so much. If I work in a grocery store, for instance, or healthcare setting, that would be nearly impossible if I still need to go to work and make money. And if I still need to contribute to my community in the ways that healthcare workers and grocery store workers do. So not all populations have the same access to preventions, even when we know prevention mechanisms, even when we know what they are and how they work. What that means is that when we try to help people by saying things like social distance, wear a mask, get COVID testing, any kind of recommendation that we make is going to be easier for some people to use than others. And unless we overtly recognize that and design programs that will help the people for whom it's hard to use these things, use them, we might as well not make these recommendations at all, right? Because people can't just always use them easily. So the needs assessment was designed to provide all that foundation, and this is what we did. So in the lower right here, you see the 6 populations of Ohioans that we were studying, and in the results section of this talk, I'm going to focus on Asians and Asian Americans, but we also studied Black and African Americans, Latinos and Hispanics, immigrants and refugees, rural Ohioans, and Ohioans with disabilities. And so for those 6 groups, we did a lot of publicity. Dr. Munoz actually helped quite a lot, I seem to recall, with our publicity in some populations, in order to try to get people who know these populations well, who work in social service agencies or healthcare settings or community-based leaders of one kind or another, who can say, this is what's going on in my community, this is what's going on in my neighborhood, this is what's going on with the people that I know and work with. And for those people, we asked them a bunch of questions about the 8 categories listed in the upper left. So these are the CDC protections to prevent the spread of COVID-19. And there are basically 8 categories of things that we asked people to do to prevent disease spread once the pandemic began. And we asked people, as you can sort of see in the upper right, for each one of those, let's just take testing as an example. For testing, we asked, in your community, what barriers does the population face in trying to use testing? So testing is an important public health strategy. What happens in your community when people try to use it? What barriers might they face? What kinds of specific cultural or situational concerns should we keep in mind when we are encouraging the people that you live around and work around to use testing? What ideas do you have about how we can help members of the population use the encouraged practice? And can you tell us any stories about testing and how it's going in your community? Those stories were meant to make it easy for people who are the experts on their own community to tell us what's going on in any way that worked for them. And this was a survey that was done online, but all the questions were open-ended. So it was like, if you answered this survey, you got a question, and then you just got an open box in which you could type anything you wanted in order to help us understand what was happening in your community. We also asked people to describe strengths of their communities and to give us names and contact information for trusted people in communities who are offering help and can be counted on as resources later. The analysis process was multi-stage and iterative. This, for an academic project, is astoundingly quick, the timeline that you see here. Basically, we began designing the survey in April, started data collection in mid-May. We started disseminating our findings and talking to community organizations and local public health agencies and state agencies about how they should use this information by July. In the middle of October, we publicly released the final needs assessment report so that everybody could have access to it. The whole process was really a labor of love, and I just sort of want to take a moment to thank the huge number of people who participated. Nobody got paid for this work. Nobody got reimbursed for their time. This is about people wanting to serve their communities, and from the leaders of the project to the coders and the people who worked on the data and the people who helped us do the design work and the translation. It was really about people pitching in to try to help communities that might be vulnerable around the state of Ohio have what they need to be able to respond well to COVID-19. And in particular, I'd like to highlight these members of the expert panel for Asian and Asian American communities who spent time with us looking over our data and how we were interpreting it. We gave them early results and bits of writing, and we asked, how are we doing? Do you think we're understanding things correctly? Do you think we understood what our informants were trying to tell us? Can you make any recommendations about how we should add information? These experts really helped us to get it right as best as we could for Asian and Asian American communities. So thank you to all of you. This was a critical service. All right, so let me give you a little preview of what's in the report, and then I'm going to talk about the results. So the preview is meant to give you a sense of, if you really want to dive deep for your own organization or your own community, here's the kind of things you're going to see. And then if you don't really want to dive deep on the website on your own, I'm going to tell you what it's okay, so here's the preview. So as I said, it's presented in a whole variety of different ways. The data is cut up in different ways and analyzed in different ways to make it easier for people to understand what they're looking at and to find what they need as fast as possible. So there is a portion of the findings section that is specifically for Asian and Asian American communities in Ohio. You can skip right there on the website to just read this part if you want, as you can with any of the other communities. It begins with a background section, which kind of describes Asian and Asian American communities in Ohio. If you are working with these communities all the time in an organization, you probably don't need to read this section. It's mostly for people who are trying to acquaint themselves newly with communities that they might be trying to serve or maybe collaborate with. And then there are kind of two key types of findings and recommendations. So on the left is an example page that is about key barriers to public health strategies to minimize the impact of COVID-19. So again, there are these 8 strategies that you see there kind of in the light blue box. And this goes on for many more pages. This is just the first page to show you how we kind of summarize what some of the barriers are, and we give detailed points on how those barriers play out. And then in those dark blue boxes, you can see quotes from people in the Asian and Asian American communities who participated and told us important information. And we use their quotes to give you examples of how people talk about this stuff. On the right is an example of a final recommendations page. The text is in orange because there's actually 3 different colors of text, although you can't tell here, because we wanted to differentiate recommendations that are things that we need to do ASAP in order to deal with COVID-19 as soon as possible. And then there are things that we can sort of take more time with because they are either not COVID-19 specific, but really affect COVID-19, or because they're really about underlying health equity issues that really get in the way of good health and healthcare across the state and need to be dealt with in order to set the foundation for communities to have better access to health and healthcare well beyond this pandemic. There's another set of findings, which is about each of the 8. So we have findings in this prior section are from each community. So there's a set of findings about Asian and Asian American communities. And then there's a set of findings about each of the CDC's public health strategy groups. So this is an example from the section on testing, where if you're not so much interested in a particular population of people, but interested in a particular type of intervention, like social distancing, how's that working, or testing, how's that working, this is the section that you want to read. At the very end, there is also a catalog, a very substantial catalog of resources for Asian and Asian American communities, as there is for each of the other community groups. Melinda Dang was actually very instrumental in putting this together, and we very much appreciate her work. I'm not sure if she's here today or busy doing graduation things with her family. But on the right is an example of from Cuyahoga County of some of the resources and the types of information that are listed here in order to help people access resources that might be COVID related. We also have this table 1, which is going to be small here for you to read, but I just wanted to give you a sense of it because many people are telling us that this is like the most useful part of the report for them. And so we want you to know that it's there. It is very early in the report, and it basically says for every key audience in the state, this is the stuff you most need to do. So it encapsulates the most important priorities in as few pages as possible. There are 8 key recommendations in the report, and as you can see in the text that's kind of oriented the wrong way on the left, that's key recommendation number 1. And then across the top, you can see that we're addressing several different key audiences: state level legislators and leaders, local public health leaders, people who work in communities, healthcare providers, government funders, or funders in general, and researchers. So if you are, say, a community-based organization and you want to figure out how to do stuff that's recommended in this report, you just need to look at the one column, that third column over that says centers with community. And you can sort of skip the rest. And those are customized recommendations for that group of people. Okay, so that's my little overview. Let me tell you what we actually found. So as I think I have sort of talked about, we were thinking about 6 communities of people, and we were thinking about 8 types of prevention activity. And when we did the analysis, we kind of went about it that way. We thought we're going to tell you findings for 6 communities, and we're going to tell you findings for 8 types of intervention. And we did that. But what actually happened was that the more we looked at the data and the more our analysis proceeded, the better we understood that there were really key things coming out for everyone. They were coming out for all communities across the state, although in certain ways, different for some communities than others, but with nuances, they were coming out for all communities across the state. And they were also coming out as relevant to all kinds of protections. So the types of things that communities need in order to make sure that people can get a COVID test when they need one are not disconnected from the kinds of things that communities need to make sure that they can social distance or wear a mask when they need to do that, or quarantine. And so we ended up coming up with these top level recommendations. These are our top level needs assessment recommendations to assure equitable access to COVID-19 protections. And there are 8 of them. I'm going to go into more detail about each one. And I just wanted you to be able to see that there are these basically 8 sets of recommendations. And what I'm going to do now is walk through them one by one, specifically looking at how they play out for Asian and Asian American organizations and communities and individuals based upon the data that we gather. So the first recommendation is to center the COVID-19 response in the organizations and cultures of local communities. As many of you know already, sorry, my animation isn't working great there, so ignore the thing on the right. Just look at the quotes here. But, I think that people who work in communities know this well, but for an official set of recommendations, it is absolutely critical that we recognize that if we are trying to help communities, particularly communities that may be unusually vulnerable to getting or dying from COVID-19, we need to be basing whatever work we're doing, whoever that we is, in those communities themselves. So because community organizations and leaders are the people who are trusted, those are the people who know what they're doing, those are the people who know how to actually address community members. And if we don't let them do the work, it's not going to get done or it's not going to be effective. So anything else that happens has got to be partnering with or working through those organizations. In the green text there, you see some example quotes from our informants. For instance, community members will listen to authority, especially if the representative is Asian, partner with churches or Asian markets, talking about Asian-owned pharmacies. So these are like examples of suggesting particular community-based partnerships. On the right here, I just want to highlight some sort of aspects of what it means to center the COVID-19 response in local communities. It means engaging with community organizations who specialize in working with specific Asian or Asian American populations. Those are ethnic health organizations, community federally qualified health centers who work with particular groups of people, and so on. Utilize community health workers. Community health workers are an amazing resource that some organizations and communities have more access to than others, and many more community health workers are being trained in this pandemic because these are people who have basic understanding of the really key health issues. They specialize in certain things, but they spend their time talking to community members and working with community members. So this isn't about seeking out healthcare or a doctor. This is about having somebody go into your community, into your church or temple, and explain what's happening and answer your questions and connect with people in their own languages because they're from the same communities. Language is really key here, and this is going to come up over and over again, that obviously we need health advocates who speak the languages of the people that they're trying to speak to. And those people can be bilingual or from the local communities, and at the very least, we need translation when that's not available. Community resources should be used to spread information, and that can include things like ethnic social media, churches and temples, TV, or whatever organizations are being used normally for people to get information. That's where the COVID information should be. And also, native language speakers need to be used to do a lot of the critical things in the COVID pandemic. So for instance, if contact tracing is really important, which it is, and we really need people to participate in contact tracing, well, then those contact tracers better speak the languages of the people they're trying to talk to. If you're trying to talk to somebody who's just been diagnosed or somebody who's been exposed to somebody who was diagnosed a few days ago, you have to speak the language of that person, because trying to get through in English, if the person isn't comfortable in English, isn't going to do it, and you're not going to get the message across, and maybe not even be trusted. So we have selected recommendations here. This is the type of thing I was talking about in table 1, but just some examples of the types of things that we say to, in this case, we're making recommendations to local public health leaders so that's, for instance, Columbus Public Health or Franklin County Public Health Department. And we're suggesting that they seek out community members and leaders to help inform their COVID policies, bring those people into committees, help the state leaders understand whoever the communities are that are big in your area and that need to be served. Apply to COVID-specific funding, and approach community organizations, churches, ethnic groceries about being partners. Okay, the second main recommendation is to explicitly address economic injustice and its widespread health and social impacts by providing resources directly. And this is an example here from one of our informants who says, we have caseworkers regularly doing home visits. Because we know that some community members do not have access to transportation, culturally specific groceries, cleaning supplies, and information. Our caseworkers always wear face masks, which helps community understand the importance of health guidelines and receive proper updates. And we know without our regular drop-offs and regular services, many of our families won't have adequate basic hygiene needs met. So this is about meeting people where they are and getting the resources to them directly. Couldn't be more important. Among other things, we need to facilitate ready access to all of the kinds of supplies that protect people from COVID-19, from cleaning supplies to masks. That means making them available and accessible at local sites and places where people already go, and delivering them to homes when it's necessary. One of the multiple of the key sets of recommendations from the CDC are that people who have COVID-19 or were exposed to COVID-19 need to be staying home and away from work. And that means we need basic financial support for people who cannot work and need to be in quarantine or isolation. We need to increase the accessibility of testing and contact tracing in local community sites, and improve the accessibility of healthcare, make sure that people are linked to healthcare so they don't just, for instance, get a positive COVID test and then have no place to go if they need help. Make sure people have internet access for free if necessary, because that is where a lot of the information is circulating. Mental health services have become particularly prominent in the, I think mental health services are always an issue and always underfunded and less available than we need them to be. But now I think these have become particularly important for Asian and Asian American communities as we have dealt with stress and trauma related to COVID-19, mask wearing, and horrible racist instances that have been going on since the beginning of the pandemic and only seem to be accelerating recently. So we know people need support in dealing with that at the individual public mental health level, as well as at the policy level. Those things have to be addressed. So again, here we have some recommendations for local public health leaders about the kinds of things that public health agencies can be doing to help facilitate the right kinds of responses to people who may not have access to resources right now that they need in order to protect themselves from COVID-19 and its effects. And we need to make sure that we involve our local public health agencies in using their resources to fix that problem. Number 3, directly address racism and reduce immigration-related fears. This is absolutely critical. It actually is in one form or another important to all the all the communities that we studied, but it is particularly important in Asian and Asian American communities because we have seen anti-Asian abuse and violence and discrimination kicking up and specifically related to the COVID-19 pandemic. And these things have affected individuals and families and whole communities, as I know many of you know, and we have to be able to address these things directly. So it's partially about racism, it's partially about discrimination, and it's partially about immigration. We have many communities across the state for whom immigration is a serious issue. We have many people who are documented and in the United States legally who are scared to access healthcare resources and health resources in general, because they're afraid of immigration authorities for their own community. So this is about people who may not be documented and who are here and who need to have their health protected, but it's also about the people around them and all of the ways in which they are also scared for their entire communities. If these kinds of fears are not addressed, then we are not getting people in the door for health care, for testing, for contact tracing, to talk about, how to quarantine properly, and so on. So we need to separate COVID-related activities from immigration authorities and law enforcement in general. People need to be reassured that their testing and contact tracing information cannot be shared with any government entity other than the healthcare entity that was taking care of them. We need to make sure that healthcare and public workers all have implicit bias training at the very least, and preferably are culturally competent to deal with the populations that they serve. We need our leaders to make public statements directly condemning racism and discrimination, naming this language when it comes out, no matter who's saying it, and saying this is inaccurate and is not helping. And we need grassroots support to help encourage and report help encourage people to report bigotry and discrimination when they experience it, so that those things don't go unchecked. Here are some, in the interest of time, I'm not going to focus too much on the recommendations, but there's selected recommendations here for universities and researchers, in particular, things like contributing expertise to policy conversations about COVID-related protections in the workplace, or understanding the impact of discrimination and racism, or other policies and ongoing situations that researchers can help be informative about. All right, the next recommendation is to strengthen employment policy and other relevant public policies. Here we have some quotes illustrating the types of jobs in which people are particularly in need of protection. Employment policy, public policy in general is critical, of course, but employment policy has a special place because people need to be safe at work, and they don't necessarily control the conditions of their own work. So if we don't have employment policy that protects people at work or in the places in which they do business, then people don't necessarily have the option to do that for themselves if it's not legally required. So we need to mandate employer provision of PPE to anybody who's an essential employee. We need to allow people to work from home whenever possible and make it mandatory that sick leave be allowed when people need it. Sick leave is particularly critical for essential workers because essential workers can't necessarily take sick leave. And in a situation like the pandemic, we need to make sure that there's a provision for that to be possible, at least now, because we don't want people at work when they are ill and could potentially be transmitting a virus. We want them at home. And that probably means that they need a policy where they can get paid while they are out sick. We need to improve COVID-related protections in work and retail sites, and pay particular attention to sites in which it's not so easy to wear a mask every day, for instance, and figure out how do we compensate for that with social distancing, for instance. And we need to support small businesses and minority-owned businesses to make sure they have the safety measures that they need. This is the kind of thing that we can all be paying attention to, even in the organizations where we work. Even in health and social service organizations, we need to make sure that our workers have access to the right protections for themselves so that they can be protected while they're out there trying to protect others. Increase access to affordable, low-density housing. We heard from many of our stakeholders in Asian and Asian American communities about how many Asian families live in very limited space. There's a lot of multi-generational homes and multi-family homes where people really are routinely spending time with people that are not in their immediate family, and really that number of people in the same place makes it harder if somebody is exposed to the virus for everybody else to be distancing and protecting themselves for the period of time that's required. Increasing availability of affordable, larger housing would be helpful. Making it possible for people to have a pause in their rent or utilities. So because in a housing crisis or in an economic crisis, people lose access to housing, and then they end up cramped into even smaller spaces because they move in with other people, thereby increasing risk of transmission in what become sort of congregate settings. Make sure that people who are wanting to isolate or quarantine because of a COVID exposure have the option to do that. Reduce crowding in congregate living situations. That includes things like halfway houses or university living spaces, prisons, and so on. And make sure that people have things that they need in order to be able to isolate or quarantine, such as if you're a caregiver for an older person or a child, you may need a substitute caregiver provided to you by, say, a public health agency or a social service agency in order to be able to get a little more distance from people if you become ill yourself. This is, again, things that community-based organizations can become involved in through things like getting funding to support rental and utility assistance programs, or help people learn how to use COVID protection measures at home. Along similar lines, we have the recommendation to improve public and shared transportation services. Many, particularly in lower income communities, we have a lot of people who do not have their own private transportation. And so people are really reliant on public transportation or rideshare services in order to get where they need to go. And if transportation spaces aren't safe, then they become a place where people can transmit COVID-19. So We do need to provide support for agencies that provide transportation to healthcare and social services. This has actually come quite a long way since the beginning of the pandemic. In rural areas, there may not be public transportation or rideshare services, and so people have no choice but to carpool in large groups when they need to go to work or the market or whatever. So creating financial incentives to bring rideshare services into those communities would be helpful. Public transportation networks could, when they go to retail and healthcare sites, assuming that they have distancing and barriers and whatever on buses, can be very helpful. And it is possible to renovate public transportation vans and buses to make them have better airflow and be less likely to be places where COVID-19 is transmitted. This, of course, involves a lot of things that we need state and local leaders to do, like investing money in public transportation systems or rideshare services in order to make those available. We also need the quality of COVID-related education to come up and to increase its dissemination. I think that this is about making sure that the right people are providing the information, people that are trustworthy, that the information is being provided everywhere, and that it's being provided in places where people, in ways that people can really access it. So we do need mass media campaigns, but we also need to make sure that local organizations are providing educational materials to their communities, because their communities trust them often more than they trust a big government entity at the state level. It can certainly help if we could provide those local organizations with materials that they can use in the languages in which they need them. The terms that we educate people in need to be easily understood and culturally relevant, again, in the right languages and with the right images, so that it's clear this is relevant to me and my community. We can use all kinds of modes to educate people. It doesn't just have to be PSAs. It could be webinars, video events, things like this, mailers and flyers, TV and radio. And we need to use people's own stories. So community members need to be able to talk to their own communities about how COVID has affected their own families and what they think about vaccines and so on. We do recommend that healthcare institutions and providers become part of this whole educational effort in order to really make sure that while you're interacting with your healthcare clients, you're also providing education and information about COVID-19 as they need it, because healthcare institutions are a trusted source of that information often. And then finally, it's really important that we address language and communication barriers. As you can tell, this has already come up over and over again with respect to some of the other recommendations, but it is in and of itself an issue. It's really clear with Asian populations how much we need to be speaking to people in the languages that they speak. We have plenty of Asian and Asian American people in the state of Ohio whose English is very comfortable and for whom delivering information in English is fine, but that's not the case for everybody. And also people need to be able to resonate with the information. So sometimes even people who can understand something in English would really rather see it in another language that feels like home to them and where they feel like that information is really about me. Visual aids are also really important. Not all groups have high literacy or high health literacy. And many people at all different levels of education absorb educational information and information that's relevant to their own healthcare decisions better with visual aids. We need to make sure that anytime you go into a healthcare related situation, you have access to those services in whatever language works for you. It's hard to get vaccinated or participate in a contact tracing conversation if you are struggling to focus on the language or what the person is asking you. We need to make sure that we use plain language so that it's not too sophisticated, so people can focus on the decisions they need to make and what they need to do, and not on dealing with something super complicated. And of course, we need to make sure we're using the languages of the community. Again, there's a lot of place here for funders. We have a lot of great ideas in this community about how we can, translate and offer services in the right languages. We just need to make sure that those people are hired and those materials are created. So that's sort of the main recommendations about what we think needs to be done, which leads us with the question of how do we think about getting all of that done, right? That was a pretty long list of stuff that needs to be done for communities. And so we ask ourselves, how can we get all of that done in order to ensure an equitable public health response to a pandemic? And this is the basic recommendation. Build multi-sectoral collaborations that support trusted existing centers of community to function as centers of COVID-19 response. So first, that means we have to take a multi-sectoral community-based approach. That's why I'm talking about social service agencies and healthcare institutions and community-based organizations and government funders, right? Because it takes a lot of different people filling in a lot of different parts and knowing that they have to work together in order to be able to solve these kinds of problems. We need to remember something that is often forgotten, which is that we aren't dealing with one COVID-19 problem at a time. If we are dealing with vaccines, for instance, we are not only dealing with vaccines, we may also be dealing with people who need to think about quarantine, who need to think about mask wearing. And any opportunity to talk to people about one of these things is an opportunity to make linkages between everything that's related to the pandemic. Our interventions need to be launched at multiple levels. Some of the things we need to deal with are about access to financial resources, like things like giving people a housing voucher. And some of the things are much more specific or at the individual level. And we need to be thinking at all those levels in order to understand where's the best place to intervene. This is a graphic that I just want to spend a second on because I think this is really critical. And this is something that so many Asian American organizations that I have had the pleasure of getting to know in the last few months are working on. I know the Ohio Asian and Asian American Health Coalition has done some of this work. Melinda was telling me about Asia Inc., who has done testing and vaccines in Summit and Cuyahoga counties. These are examples of organizations who have moved beyond whatever their original, idea of what their job was, right, to include COVID-19. And some of them, like a health coalition, that's sort of a small leap. And in other cases, it's maybe a big leap to say COVID-19 is the thing we need to be dealing with now. But a lot of times we have these centers of community. Those are places where just anything that's operating in a community center or an organization. And those centers of community may have the desire to do something about COVID-19. The things in the green ovals are what they need to get there. So they need collaborators who can bring in the right expertise and resources to make it possible for them to become centers of COVID response. And they need funding in order to, from private donors or from government agencies or whatever, in order to be able to expand and do all of those things. So if you're an organization who has been, say, primarily an educational organization, and you're going to hire some contract tracers or some community health workers, you could do a whole lot of really useful stuff. That's examples in those little orange boxes at the bottom, but you're going to need some funding and some expertise to help you do it. Community health workers, as I said, can be really helpful in a whole variety of ways. And I think the more community health workers we can train and bring into this work, the better. And overall, we need all of the involved parties to be collaborating to align their goals and strategies and really maximize progress. So we need to be talking to each other and communicating about what are our goals, what is the impact we're trying to achieve, and what are the pieces that each of us can bring to that enterprise. Okay, so I'm sure you've heard enough about the needs assessment and all of those recommendations. I know it sounds like a lot of stuff, and I'm happy to answer questions and talk in detail. I also want to just express my thanks again to those several of you who are on this call who were part of that process in one way or another, and just to reassure you that this material is being disseminated all around the state, and we are hearing from lots of people how they're learning from it and what they're building on it. So all the efforts that you've been put in are going to all kinds of places, many of which I don't even know, where people are using that information. If you want to work with us more, we are actually continuing this work. We have a COVID-19 and vulnerable populations work group at the College of Public Health at OSU, where we continue to do work on a whole variety of things. Melinda Deng, who I know works with some of you, has also been a member of that group, for instance, designing educational materials for Asian American groups in Ohio. And we continue to do work to try to apply this work, the findings of the needs assessment in specific places, such as how do we get vaccines out into the communities that need them? What are the problems we have to solve for those communities in order to do that? And how do we make that happen? So we're using all the principles I just talked about to solve those problems ourselves. And we would be happy to talk to people who are interested in getting some help to do that work in your own organization. I'm happy to share these slides. If you all, I don't know if you're distributing slides or you just want to distribute some links, all of that's fine. I just want to point out, again, the complete report and all the component parts of the report are available online. The executive summary itself is also available in simplified Chinese, as well as Spanish, Arabic, and Somali. Please feel free to distribute that wherever you would like. And we have an email address. You probably have my own email address, but we have one for the project and all of our COVID work, and it is monitored regularly so that we can try to form partnerships and help people who are working in this area that I think we're all so passionate about right now. So thank you again, and I really appreciate the time to talk to you all today, and look forward to the rest of the conversation.
Thank you so much, Dr. Padamsi. A lot of information that you have shared with us, and really great recommendations that really we need to look at and apply as community organization. I believe at this point, Suchi will be introducing our next speaker. After Dr. Somani speaks, then we will have a question and answer period for both speakers. Go ahead, Suchi.
Yeah, thanks, Cora. Just let me share my screen. Can you guys see my screen?
Yes.
Okay, am I audible enough, I hope? Okay, so good evening, everyone. My name is Shuchi, and I got an opportunity to introduce Dr. Anita Somani. She is with us here on this second day of the webinar. So Dr. Anita Somani is an obstetric gynecology at Ohio Health in Columbus, Ohio. She has been in practice for 28 years. That's pretty impressive, Dr. Somani, and has had the privilege of delivering babies of babies that she delivered early in practice. That is certainly an achievement. She is an expert robotic surgeon and has been teaching robotics to other surgeons for the past 11 years. She has 2 millennial children. Her oldest is an engineer and is a Democratic delegate from Detroit, while her youngest is an obstetric gynecologist resident and politically active with organized medicine. Dr. Somani is the co-chair of the Physicians Action Network Board. She is the past president of the Columbus Medical Association. She is also a first-generation immigrant whose parents migrated here from India. Welcome, Dr. Somani. It's a pleasure to have you here on this forum. Please go ahead and share your valuable insights.
Can you all see me?
Yes.
Thank you for including. Thank you so much for including me in your webinar this evening. As you all know, I specialize in women's health. And as a result, this past year, I learned had been very, very hard, especially hard on Asian Americans, on women who are often essential workers. My sister, my daughter, and I all worked through the pandemic and saw so many of our colleagues get COVID. We saw patients who had gotten COVID. We saw pregnant women who ended up in the ICU with COVID. But we were very fortunate to have enough PPE to consistently wear masks and avoid getting sick during that whole process. So when we heard, the Operation Warp Speed and the vaccines were approved, we were the first groups to get in line for the vaccine. We were just like, oh my gosh, this is a lifesaver. From a mental health, from a peace of mind, it was one of the most important things I could have done. It made me feel more comfortable for my parents who are in their 80s, that they were okay getting on a plane. It was okay for them to start traveling and getting out of the house. There was no question in my mind about whether to get it or not get it. And when people asked, well, what vaccine did you get? My comment was, I don't care what vaccine I get, I'm just getting vaccinated. And we know when we look at history that, this was pretty incredible how fast these vaccines were developed. But the reality is the technology for the vaccines had been around for a long time. So it wasn't something that was new technology. It was more the idea that this was, that technology was used for the new virus. And we also have seen from history that diseases like smallpox and polio disappear because of vaccines and herd immunity. And because oftentimes countries where vaccines aren't as prevalent see these diseases, those people are more likely to then get in line to get vaccines. However, in the Asian American community, we are seeing some vaccine hesitancy, and that's something that we as physicians that are from that Asian community want to address. So as an OBGYN, my focus is on women's health, on taking care of mom and baby. So last year when I was delivering patients, I was delivering babies, you know, the question kept coming up, how is COVID going to affect me? How is it going to affect my baby? And at first we were like, oh, it's fine. It's not going to hurt you at all. You know, patients are delivering, babies are healthy. But what we're learning as time has gone on is that if you get COVID, it can affect the placenta. As you all know, it can cause those little microemboli or small clots to form. So that's why you hear about people getting blood clots or, you know, the pulmonary clots, those things. And that's something that we're starting to see in our pregnant patients who get COVID. So the idea of COVID affecting the placenta and then leading to growth restriction because of the microclots or the small clots that are in the placenta. So, you know, when the vaccine came out, people were asking, should we give it to our pregnant patients? Should we not give it to those patients? And fortunately, we all agreed based on the technology, based on the fact that it's not a live vaccine, that the medical organizations, including American College of OBGYN, came out saying that our pregnant patients should get the vaccine. So right from the beginning, right from when it was approved, we were offering it to our patients. And we know because the first patient that delivered at 37 weeks who had been vaccinated, her baby actually had antibodies and was protected from COVID right from the start, right from birth. So that was very encouraging, and we're seeing that more and more. So again, it's super important if you're pregnant that you go ahead and get the vaccine. You know, it doesn't matter what trimester you're in, just get it. And then the other place we were concerned, and as a physician, we were less concerned, but we were getting a lot of questions about fertility. Patients were asking, you know, is it going to affect my fertility if I get the vaccine? Do I have to wait to get pregnant? You know, as we tell people when they get MMR, they need to wait 3 months because that's a live vaccine. So the question would arise, you know, is this going to affect my fertility? There's been a lot of misinformation out there as far as people thinking that if they're close to someone who got the vaccine, that shedding of the vaccine or the virus would then lead to them becoming infertile. But we know that technology is not such that you're shedding the virus. The virus is not something that is given to you. It's the technology that enables your immune system to create antibodies against the virus. So when someone asks me, you know, can it make me infertile if I'm near someone and they shed the virus, what'll happen? I kind of have an interesting analogy that I say, you know, basically it's like saying, if I'm standing next to you and we have similar cell phone numbers and someone calls you, they're not going to get me, even if our, you know, 2 or 3 numbers match. So that same idea of the vaccine causing someone to become infertile just because you happen to be in the same room or near them doesn't make any sense. So that's something that we really, really are trying to, you know, dispel that misconception. So as physicians in the Asian American community, we recognize that talking to our patients, you know, letting them understand how important it is to get vaccinated. So in order to do that, we are in the process of putting together a video that is going to be in multiple languages and languages that are predominantly seen in our community here in Central Ohio. And we want to help those people who are vaccine hesitant to understand why it's so important to get the vaccine. And I think we all know after living through this last year's pandemic, and I had friends who were introverts who were like, oh, this is great. This is the way I want to live my life. But even those people who are, you know, by heart introverts also felt like they missed seeing their families, they missed seeing their parents, their grandchildren. You know, the idea of endlessly being cooped up and being limited in what you could do, you know, not being able, like for my parents, the temple, for us not being able to go see a concert or go to a show. Those are things that now, having been vaccinated, I'm so much more comfortable. I feel better, even though I may wear a mask because I don't know about people around me, whether they've been vaccinated or not, but I still think that it gives you that peace of mind to get out. And then the other question we hear a lot is, well, I'm not going to get the vaccine because I'm going to have to get a booster in the future. Well, getting the vaccine today will help us all get to that herd immunity to be able to get to normal tomorrow. So again, if people ask you, those are some sort of key talking points. Number one, it's safe for everybody. It's safe for pregnant women. They're starting to now offer it to teenagers. We're starting to see studies even in young kids. So overall, it is a very, very safe vaccine. And, the Johnson & Johnson did get pulled. So there was a question of, the blood clots, but that risk was so small that within a week they had released it and said, no, we will continue to give the vaccine. So at that point, I know I've given some really key points, but as my focus is women's health, I want you all to recognize that, the importance is for women who are planning to get pregnant, women who are worried about fertility, it is safe to get the vaccine. And if you want to get back to your normal life, where you can go to concerts, you can go to restaurants, you can get out, no matter what it is, you want to travel, whatever you're interested in doing, we're going to be able to do that more effectively if we're all getting vaccinated. So thank you. And I'm happy to take questions.
Thank you so much, Dr. Somani. Okay. We will open up to questions. And I know Dr. Padamsi is still here. Let me just look at the questions here. Has any studies done with correlation of smoking and susceptibility, severity, and or death with COVID-19 infections? Anyone could, maybe Dr. Padamsi would respond to that question?
Sure. Yes, I'm happy to give it a shot, although I think Dr. Somani's I'm happy to defer to you with the medical expertise. But my understanding is that really with smokers, I think what we're talking about is that there is an association with lung disease, and because we have a high association with smokers, particularly if you've smoked for a long time, or at a large dosage amount, that the likelihood of lung disease among those people is very high, and that lung disease is associated with worse health outcomes for people who get COVID. That doesn't mean it's going to be a one-to-one correspondence for everyone, but certainly it is a higher risk, not so much of getting COVID, but of the types of outcomes you could see if you do.
Agree. So there's nothing specifically about smoking that's been studied, but what we do know about COVID and what we learned very quickly early on was that comorbidities created a worse outcome. So what we were seeing were people who had a BMI over 35, people who were smokers, people who had heart disease, those people were becoming much sicker and much more quickly than people who had did not have underlying health conditions. Now, as time went on, we were able to treat people more effectively. We knew sort of when to treat them. So those things led to better outcomes. Because if I think back to, last April and May, when we were seeing just an enormous amount of deaths compared to now with people getting vaccinated. I mean, one of the biggest changes has been in the 75 and older group. Even with comorbidities, those who are vaccinated have better outcomes if they happen to get COVID after being vaccinated, which is rare, but can happen. It's just like when people talk about the flu vaccine, oh, I got the flu, even though I got the vaccine. Well, yes, it can happen, but you're not going to get hospitalized. You're not going to end up with a severe, COVID. You're less likely to have long hauler COVID where, you've got underlying pulmonary conditions or underlying cardiac conditions that you're going to live with for the rest of your life.
There is a question about underlying disease. And so what kind of diseases or ailment are at the highest risk on COVID scale? You mentioned chronic illnesses, as
right.
Anyone could respond.
So age plays a role. The older, if you remember, early on, it was people in nursing homes that were most severely affected. The biggest comorbidity, which is why I think we saw it much more significantly affected, was obesity. You know, America has a very high percentage of obesity when you think about our population. And so early on, like countries like Singapore or countries in Asia, they weren't seeing the really devastating outcomes that we saw early on and in younger patients. And my sister, who's infectious disease in Singapore, said the only thing that they could see that was made a difference was the younger patients with high BMIs had worse outcomes, probably just because of the obesity and the fact that they did have maybe underlying heart disease that hadn't been detected, or underlying diabetes that really hadn't been detected at that stage. So I think the biggest underlying conditions that I would talk about, what would consider in terms of outcomes for COVID, are age, heart and lung disease, so smokers, and then obesity. You know, whether, no matter what age you are, obesity plays a role in terms of outcomes.
Thank you. Anything to add, Dr. Padamsee?
No, that sounds great to me. Very
Okay.
thorough.
I just want to point out that last night when we had our keynote speaker, he talked about BMI for Asians, which is now screened at 23. So to remind everyone, it is not like 25. So at BMI with 23, we need to have some, you know, medical or kind of guidance for that.
Right, and
Thank you.
That has a lot to do, Cora, with the fact that Asians in general you will see diabetes, you'll see polycystic ovarian syndrome, insulin resistance at lower BMIs than you ever would see with Americans. And we see that even in Native American Indians also. So again, that's the reason for lowering the BMI in that group.
Yes, thank you. Thank you for. And then there's an additional question here. What could be the degree of COVID infection for a vaccinated individual who has pre-existing illness and also recovered from COVID?
So I'm not sure if that question is asking, like, would that person be more likely to get COVID again? Or are they more likely to have a severe? So far, what we know is that people who are vaccinated that then are exposed to COVID or get COVID again have a much milder course. They're shedding less of the virus, so they're less infectious to others. But I don't know if that's answering that particular question, but it's another reason to consider getting vaccinated so that you're less likely to shed the virus if you were to get infected, and you're more likely to have a much milder case of it if you were by chance to get it after being vaccinated.
Okay. Thank you very much, Dr. Padamsee and Dr. Somani. We really appreciate your sharing with us your great insights and really guidance for us during this period of pandemic. I just want to mention at this point that the Ohio Asian American Health Coalition is completing a project, and it is a media campaign for vaccination. And Dr. Somani is part of that group, as with 8 other Asian physicians. And we're very, very excited to let you know that the vaccination message will be in the language of those 8 Asian physicians, different languages. It will be presented and tailored messages for their own community, talking about authority and trust and credibility. This is what we're doing right now, and it will come out soon. The videos will be ready soon, and also there will be information that will be translated in several Asian languages, because our experience is that mostly simplified Chinese, that's translation, and that's not all the Asian languages. So we're doing it to several Asian languages. The video will also be by Asian physicians in their language, in their cultural nuances, addressing all the specific of needs of that community. So we're very excited to share that with you, and we'll update you. And yeah, it is an exciting campaign. Dr. Samani, thank you so much. You're part of that from day one. And of
Thanks,
course,
Cora.
Manju spearheaded that.
Yes, thank you, Cora and Manju. Appreciate you asking me.
Thank you, Dr.
Yeah.
Samani. We love you. Thank you so much.
Bye-bye.
Thank you
Bye.
again, Dr. Padamsi and Dr. Samani. We will
Have a
continue
great dinner.
this
Happy
program.
Mother's Day to everyone. We did not say that to begin.
Oh,
Happy Mother's Day.
happy Mother's Day. Take care, everyone.
Happy Mother's Day to everyone. But we will continue this program by just reminding you that we are celebrating the National Asian Pacific Islander Month. Okay, it's also the National Nurses Week, and it's also the National Teachers Week, and it's also the Jewish Heritage Month. So there's a lot of celebration. Mother's Day weekend for us. But what I want to just point out that the Ohio Asian American Health Coalition is a consortium of 8 Asian grassroots organizations across the state. Dr. Padamsi mentioned Melinda. Melinda has worked with all those agencies in her project. I know I work closely with her as well. And so Ohio Asian American Health Coalition is a state organization of 8 community agencies, and some of them are represented here. I know Karen is here from Asian American Community Services. And so I just want to give you a little bit of a background of this National Asian Pacific Islander Month. This started actually in 1979, and it was just Asian Pacific American Heritage Week. And then in 1990, President George H. Bush expanded the celebration to cover the whole month of May. And why is it May? May was chosen because it recognizes May 7, 1843, as the date the first Japanese immigrants arrived in the United States. Also on May 10, 1869, it marked the completion of the Transcontinental Railroad, which would not have been possible without the contributions of Chinese Americans. So this month really is celebrating the contributions of Asians to this country. And I would like to also read to you excerpts from President Biden's proclamation of the Asian American and Native Hawaiian Pacific Islander Heritage Month 2021. And it says, this May, during Asian American and Native Hawaiian Pacific Islander Heritage Month, we recognize the history and achievements of Asian Americans, Native Hawaiians, and Pacific Islanders across our nation. In the midst of a difficult year of pain and fear, we reflect on the tradition of leadership, resilience, and courage shown by AANHPI communities and commit to the struggle of these communities for equity. These communities make our nation more vibrant through diversity of cultures, language, and religions. There is no single story, but rather a diversity of contributions that enrich America's culture and society and strengthen the United States' role as a global leader. We celebrate and honor the contribution of this community in arts, law, science, technology, sports, and public service, including the courageous AAN HPIs who have served on the front lines of the COVID-19 pandemic as healthcare providers, first responders, teachers, and other essential workers. I know in this audience we have some nurses, and they're the frontliners and first responders. And the president continues to say, our nation celebrates the achievements of Vice President Harris, the first person of South Asian descent to hold the office of the vice president. She has blazed a trail and set an example for young people across the country to aspire to follow, including members of our communities and women in particular. My administration recognizes the heightened fear felt by many Asian American communities in the wake of increasing rates of anti-Asian harassment and violence during the COVID-19 pandemic, and increasingly observable layers of hate now directed toward women and elders of Asian descent in particular. Our nation continues to grieve the senseless killings of 6 women of Asian descent in Atlanta and the unconscionable acts of violence victimizing our beloved Asian American seniors in cities across the country. Acts of anti-Asian bias are wrong. They're un-American and they must stop. My administration will continue to stand shoulder to shoulder with these communities in condemning, denouncing, and preventing these acts of violence. And so, Vice President Harris and I affirmed that Asian Americans, Native Hawaiians, and Pacific Islanders make our nation stronger, and I urge my fellow Americans to join us this month in celebrating Asian American, Native Hawaiians, and Pacific Islander history, people, and cultures. Now, therefore, I, Joseph R. Biden Jr., President of the United States of America, by virtue of authority vested in me by the Constitution and the laws of the United States, do hereby proclaim May 2021 as Asian American and Native Hawaiian Pacific Islander Heritage Month. I call upon the people of the United States to learn more about the history of Asian Americans, Native Hawaiians, and Pacific Islanders, and to observe this month with appropriate programs and activities. In witness therefore, I sign Joseph R. Biden Jr., President of the United States. How wonderful to hear it from our highest officer of the land, our president, acknowledging us as a people and recognizing our heritage and our contribution to this country. I want to remind you all to please fill the evaluation. The evaluation that is, the link is now posted. And also to remind you that next week we have day 3, 4, and 5. As you know, this is a webinar series. So next Friday, the focus will be on diabetes, cardiovascular diseases, hepatitis B, and nutrition. And we have 3 panel presenters. On May 15, we'll focus on mental health and coping strategies. Mental health was mentioned as a problem that has been existing, but continue now seem to have an increase in its incidence because of our situation with isolation and quarantine and all of this fear and anxiety associated to the condition and the situation that we are in. And lastly, on Sunday, we have an all-day mental health first aid training program from 9 a.m. to 3 o'clock. And this will require a 2-hour prep preliminary course that you need to take before you could join the Sunday training. If you decide to register for this training, there will be special incentives, and you will also become a certified mental health first aider for 3 years. And you will learn special skills to handle behavioral issues and mental health challenges that we see around us all the time. Our families, our friends, our neighbors, our co-workers, and we don't have enough mental health professionals. So if when you go through this training program, you will learn the skills to help others and save lives. So you will have the initial intervention. So I want to invite you to please save the dates here for next Friday, Saturday, and Sunday, and a continuation of our webinar series, and a continuation of our celebration of the National Asian American Pacific Islander Heritage Month. Are there comments from any of the team?
No, thank you. Thank
I
you
want
for
to
the
thank
great
our
job.
team. I want to thank our team, Manju and Christina, Yashuan, and of course, Suchi, who is our tech person. Thank you so much. You're a great team. And on behalf of the Ohio Asian American Health Coalition member organization, Manju, our executive director, we thank you so much for attending this. And please come back and register for our next 3 webinars. We also, and lastly,
Thank you,
thank
everyone.
the Ohio Commission on Minority Health as our funder for this webinar series. We thank Director Dawson, the Executive Director of Ohio Commission on Minority Health, who has actually been supporting us and the Asian community for many, many years, and have been really been with us and financially and funding wise given us all their support. Good night, everyone. Reminder, do your evaluation. Thank you again, Dr. Padamsi and Dr. Samani. And for all of you who attended, we thank you.
Thank you so much.
Good night.
Thank you.
Thanks, everybody.
Good night.
Thank you, Cora.
Will the team just hang up? Christina?
Yeah. I think Christina left, Cora. Yeah.
Christina was too busy.
Okay. Okay. Shaheen, we are going to have a post.
I don't know who else is there, really.
Shaheen is,
Manlita Dion?
We have 7 attending.
Yeah. They're all online.
do we still have others in the
Yeah,
room?
yeah, we do.
Yes.
Cora, thank you. You did a great job. Sorry, my nose started.
Do we still have Shaheen in the room?
We have 10 people in the room. Hello, do you have any questions?
We cannot debrief until we have
Yeah.
everyone leave the room.
Yeah, I think that's a good idea. Whose hand is up?
It's from panelist. It's your hand.
It's my hand? No, I
Yes.
just, okay.
You might click on raise your hand.
No, I did.
It's your
It's you,
hand.
Manju.
I know. That's why I'm asking. Why is it on still? See, Even when I click, it still goes up. So I don't know. All right.
You lower your hand. It's
I'm
okay.
trying. I'm trying.
Okay, I think it's just us. I
Okay.
don't think. All right,
No.
there's
No, we
7.
have Shaheen.
2 Shaheens and
Okay,
Anil
let me.
Shah.
We have officially ended the webinar. So thank you so much for participating. And we will now close this.
Yeah,
Click
we
the red
did that.
button on the side, lower side of the red button that says leave.
It's okay, Cora. We don't have any attendees now. We don't have any attendees now.
We don't have it.
None, because I don't want for us to make comments and have
Now, I don't see Yaswan.
Yashuan is on there.
Okay, all right.
I'm here. She's here.
Okay. Okay. So this one, at least we didn't have technical glitches. Hi, Suchi. Suchi
Hi.
and Yashuan,
Does
you
it,
did
it
really
seems
well.
like for last, yeah. So does it like for last few minutes, is it like crappy or cracking? Because on my
For
end,
me?
I guess
It
for
was.
audience, it was
It
was
was.
a bit,
Actually, chorus was not clear at the end. Like last 10
yeah,
minutes or
yeah.
so, you were kind of off and on freezing, Cora. Same thing with Anita Samani.
Yeah,
He was freezing. I don't,
But
why
then
did
it
Anita
picked up,
Samani
it
was,
picked back.
Pardon?
yeah, but Anita Samani was in car, so it might be the possibility.
Yeah.
Yeah, but still,
Yashuan, you did well with introduction.
Thank you.
I'm so
nervous.
Yeah,
yeah, but you did well.
you
Don't
did
worry.
well, really.
you.
That's the
Yeah,
first time
yeah.
you did, right?
I wasn't sure. There was a pause after Padamsi. Now, was I supposed to pick up? And I did because there was a pause.
Yeah, you were supposed to.
I was supposed to? Okay.
See, that's the thing we kind of, yeah, you were supposed to pick up after her. I
Okay,
just
but
felt it
I think there should be a moderator. So,
you know,
someone would say, I think this is how we should open. Okay, welcome everyone. Now Manju will do
no,
this.
that adds the time, Cora. When you have little time, you don't want to waste it. Whereas now you're using your time very efficiently.
No, but when we start, we
Yeah,
start
when we start.
exactly
Yeah,
at 6:35 after Sushi's
yeah,
puts
exactly.
it on the chat
Yeah,
at 6:30 to say we're going to be starting shortly, so they know that we're aware of time.
I
At
think-
at 6:35, someone would say, "Welcome." Now Manju will,
yeah.
or Manju, you say that.
I say that. Yeah.
Welcome everyone immediately. Okay,
Yeah.
at 6:35.
Yeah.
Okay, and then when you're done, then you introduce and then when the speaker ends, then I will pick up.
Uh-huh.
Because I need to take notes so that I can make some comments.
Exactly.
It's
Yeah, you're right.
It's
You're
not
right.
just thank you, you
Yeah.
know, so they know that you're listening and that they made some really interesting points, you know.
But, you know, Cora, one thing I would have loved to hear Padamsi talk about was how did these 6 communities across the board, how did it differ? Was there stark difference? You know, because see, some of the things I have heard, you know, firefighters are not taking the vaccinations. Okay.
Padamsi was not addressing vaccination.
I know.
That was COVID needs assessment. That's why she was talking about contact tracing and.
But we need somebody to talk about that really. You know, somebody who can really talk about.
Yeah, that's a vaccination topic. Yeah.
Yeah. Vaccination topic, how different it is. You know,
And the young people are not.
but you know, more than that, whom I thought may not take it. What are the Amish people?
Oh, yeah, because that's historical. the lady who cuts my hair, who's Cambodian,
Ah.
you know, I found out that she's not vaccinated, and I was ready to get out of the salon, but my hair was already wet. So for an hour and a half, when she was working on my hair, I was convincing her to get vaccinated,
Did she have the
and
mask?
she will not want to.
Did she have the mask?
Oh, yes. And I was vaccinated, but for an hour and a half, I was trying to convince her why she should get vaccinated. She's exposed. She has a young child. She has an older mother-in-law and all that, and a mother who's in her 90s. No, she would not. And there is no reason that would convince me that's reasonable. But
Yes.
still, she would
There are
not. So there are a lot of people like that.
People like that. Now, the reason I was thinking of Amish people, Cora, because that's probably a group we need to go out and give it. See, we haven't really identified all those people. We need to get to them.
But their communities are different in
I know.
that.
That's why we need to get them. Their
That's true.
communities are different, just like Black community. You know, not all Blacks take the vaccination.
I still have a meeting.
So,
I'll
you know,
call you
really, it's mind-boggling to me. It's a lot of whites do not take vaccination.
Yeah.
Okay.
Manju, when you asked Dr. Somani to speak, did you ask her to talk about our project?
I did. She did.
And-
I don't know. She did not talk about it. That's why I told you to talk about it.
And I thought about it already before. I said, she's not talking about it. We have
I
to.
know, yeah, I did tell her, and she
Okay.
did talk to Greg. But she
Okay,
still
so
didn't talk about it.
we made that announcement, and I abbreviated Biden's thing.
Yeah.
So
Yeah, that's okay.
so
Yeah.
what else should we learn for next time?
Well, I also thought for the next one, Shruti, this is for you. I'm going to tell you. For these two, we need to go ahead and put the report together, like our analysis of how each one went, and complete. Okay, and then the survey result. I think Yashwin is doing the survey results, right?
Yeah,
Yeah, right. So we
Yeah.
need to start putting those things together, and we need to also collect the W9 from all the speakers.
Mhm.
Okay, and
Yeah.
they have
So
not
when are you sending thank you letters?
immediately. That's why I'm going to do it tomorrow.
Okay.
I normally send it like through the chat. I sent thank you to Sumani and Padamsi already, but I have small cards. I'm going to send it out.
And are we paying? Are we paying?
Yes, of course. Yeah.
Okay, so you sending a check or you wait until,
No, I have to wait until they send me a W9. I cannot
Okay.
give them a check without that.
okay.
That's
So
why
all
I'm
three,
reminding-
all three.
Yeah, okay. That's why I'm reminding Shruti to help me out with that. Okay.
So what do you need with from the analysis point of view? So like the evaluation Yasin is doing, so that would be the evaluation, like how the attendees felt about the policy, what are the parameters we fulfilled. Apart from that, what kind of analysis, like the number of attendees, like the time duration, the topics we covered, the kind of questions we got, these kind of stuff?
And also you need to input. See, though this is all evaluation from others, you
Mhm.
also find out of that how many were Asians, how many were non-Asians, and how many of them represented, like in a case, I mean, today I can tell you there was Karen Jobu, Joseph
Yes.
Howe.
I listed them. Actually, there are 4 nurses who attended.
Okay.
And then there is Karen, there is, who is Joseph Howe is there.
Joseph Howe was there.
Who is Lilith? Lilith.
I
Do you
don't know. That's why we need to find out who that is.
Ellie Dukai. But in the
Okay.
evaluation, you write your back race and ethnicity.
They're supposed to.
Yes, in evaluation we have, but I guess everyone is not filling the evaluation form, so we won't able to get to know about the ethnicity of everyone.
Yeah.
We know based, if you give me the names, if you give us the names, we might be able to tell you.
Yeah, I can tell right now. I can tell.
Yeah.
Shaheen, Faith, Karen, Irene
Yeah.
Say.
Eva hasn't attended any of this. I need to call and ask her why.
Yeah, I know.
She was active on Facebook.
So we have 1, 2, 3, 4
had
Filipino nurses.
We
4
had
Filipino
17
nurses. And
Today,
of course,
Yeah.
today
we count ourselves, right?
Yeah, of
Yes.
course.
Okay,
You have
so
to.
4, 5, 6 Filipino nurses because Christina and myself.
Yeah, okay.
So there's 6 Filipino nurses right there.
Okay, now how do we get people from ACA? I told them that we are going to give incentive. Shuchi, we need to start pushing them.
I
I know
already
you
started
can.
promoting it.
Pardon?
No, I got the instruction from the Lakshmi to start promoting on ACA social
Website.
media and
Okay.
send the MailChimp. So I already sent it for today.
Oh, that's so nice. I talked to her yesterday, actually. That's good. Yeah.
She gave me the
Also,
instructions.
I think the topic will attract different people because
Exactly.
this is now diabetes, cardiovascular, it's not only COVID,
Yeah, next
know,
week is going
and
to
health equity. They may not be concerned about that, but they're concerned about their own, nutrition, for example. So I think we will attract different and hopefully more.
How about the Bhutanese community in Cincinnati?
I guess I have one link. I have one contact for Bhutanese
Okay.
community. I will send them the flyer and ask them to promote in their network.
Also, Sai Temple, because we gave COVID-19 testing there. So Chandra
Okay.
can help us.
I will ask Chandra ma'am to send it to the Sai Temple list.
Yeah, that
The
is-
other thing I was thinking, Manju, well,
Uh-huh.
today we were good at time. We ended
Yeah,
right on time, and even the speakers, Dr. Padamsi stopped at 7:25.
I know.
Really, that's how professional she
Yeah,
is.
that's good.
And so we were good with time. But if we have extra time, can we make announcements about what's going on with our member organizations? No.
Yeah, if they're available, if they're there, okay. But between now and next week, I want to call each one of the organization executive directors and tell them about some of the monies we have set aside.
Yes.
Organization
And to bring
10 people between now and then.
and especially the mental health first aid, Manju.
Huh?
Especially mental health first aid, we need.
Yeah, that's why now we have to start doing that. So I will do it. And also, Yasmin, since you are in a new city, you should have a lot of new friends.
Okay.
Ask them to register.
Okay.
They will get $50.
For participants in webinars?
Yeah.
Okay.
Next
No.
3 webinars, they will get $50 if they do it.
Oh, the students, yeah.
Students, yeah.
Only students or
Only
any?
students. Only students,
Only
not the graduated
No.
students. Only
Oh.
students.
Even graduate student, you're still a student. You're an undergraduate. But also when the mental
You're
health
only
first aid,
20% student.
the mental health first aid is a separate incentive.
Separate, that's $30.
Okay.
That's separate.
Yeah.
A separate incentive.
So
Okay,
the
when
next two webinars,
Should
they
we
can get 50 incentive,
Other
$50.
Other place you can see is also your old employer in Columbus. Do you have any contacts there?
Are you asking me, Manju?
Yes.
No. I don't have much contact. Like there were not much Indians. It's like pretty much
No, it
American.
doesn't have to be Indians. Listen.
the students, I sent it to Mount Carmel College of Nursing.
Yeah, but we can send it to your employer. That's what I was thinking. If you think.
If we do.
Because they have a lot of Asians there working in their warehouse.
Yeah,
Why-
they have a lot of Asians working in their warehouse, but I really don't have any active contacts there.
Okay.
I have, but I think it won't work there. The contacts which I have in that organization, I don't have the contacts with HR or the senior managers or the senior director kind of person. So I think that won't work. The Bath and Body. So what I would say, but like as far as the Bath and Body Works is concerned, and as far as their warehouse is concerned, there is a lot of Nepalis and Bhutanese community in that. So we need to reach out someone who has this in Rena's work. There must be some Bhutanese community. We can reach out them.
We have reached out, but the problem we are having with them, every Saturday they have a program going on. You know, the religious program.
Okay.
And they won't leave. You know, if it's religious program, they won't. You know, that's what.
Manju, did you
Yes?
see Christina's comment that seven out of the 11 who attended are nurses, are
Good
from her
job, guys.
contacts.
Well, just tell her she will get $50.
Yes. So Manju, are you set for next week? We need
Yeah, we need to check our
Our
self-care
program.
thing. Yes, we have to do our self-care program. And also, Shuchi, if we can send the program kind of a finalized thing to everybody by Tuesday, it will be good. There might be more people, and it starts with the weekday. I think we'll get more people.
Are you talking about the flyer, that program?
Flyer.
Yeah, that is going on constantly, Manju.
Okay.
That is like an ongoing email every 2 days. It is going to, I have made a list of around 450, no, not 350 plus 1. It is more than 500 plus contacts of like which you guys provided me. You provided me 350.
Yeah, I know.
contacts.
Yeah. You know, then we need to put that in our list. Okay. See, that's something we have to
It's in
write
our
down.
list.
Report.
It's
Yeah.
in our list. If you will go to that Google Drive, there is a one list of a mail merge. That is your whole contact list. I will add 202 participants of the site-wide, the statewide awareness forum. So that is around 359 contacts plus 200 contacts.
Okay.
Around 4:30, I send them the webinar link to the whole contact list.
how many hundreds?
I am not. I'm sorry.
More than 500.
More than
More than
500.
Yeah.
Manju, is Yifan Glavin in that list? Do you know?
Yes, she
Okay.
does. I
Okay.
put it. I sent those things to Shuchi, and also
And you guys also have received one contact center email with a webinar link because you are also in that list, in that,
I know,
you got the marketing promotional list. So
Okay. Now
at
the
4:30,
reason I'm saying,
Okay.
so mail is
reason I'm
going on
saying-
time.
Okay,
yeah, we
good.
need
Thank
to
you.
write that in the commission report. Okay, we sent this many times marketing emails to so many people.
Yeah.
They really need to know that. See, I have already started printing the 250 Cora, the cards.
Yeah.
That's getting done. Okay.
250 cards.
Yeah, because Magnum, you know, now we can get it and give it to people if we want to, because we said we're going to put 250 cards and 250 in different languages. So I need to get that flyer we have translated into at least 3 or 4 languages so we can send it out.
We didn't talk about translating information.
I did to make up all the funds you guys, they couldn't give us. Remember, there were funds they took back. So I had to make
it was added translation? Added?
Yes.
Who's
Yeah.
translating? And what are we translating?
The
Just the
flyer.
flyer?
Itself. Yeah, just the flyer.
The flyer. And what
That's
language
what I
are you translating?
I don't care, you know, whatever language. You do Tagalog and then Suchi can do Hindi.
Oh, then it
And-
has to go out right away.
We will put it up on our Facebook.
Okay. This is the first time I've heard of the translation.
Yeah, because we didn't talk
Okay,
about
that's-
it. That happened on Thursday afternoon. They gave me the approval. So
Okay. So this is new then. Okay.
yeah, okay.
Yes.
And me and
I
you
need
really
to
need
talk
to look
about
at
one
Yashuan,
thing.
can you do Chinese? Can you do Chinese translation?
Yeah.
Can you do Mandarin?
Yeah.
Okay, so you can do 2 of them then, right?
Well, that
I can get Tamil done with Shankar.
is Mandarin the national language? It's just a simplified Chinese and
Or
what is it?
traditional,
Traditional.
Yeah.
traditional and simplified Chinese.
Okay, all right.
I can do both of them. Yeah.
Good.
Okay. Okay.
Which language can you do? No, I'm asking Suchi, which language can she
Hindi,
do?
Hindi,
Hindi? Okay, that's good enough.
Hindi.
All right, sounds good.
Okay, I have one question before you guys.
Yeah.
On Friday, we need
A moderator.
Like-
2 moderators. We need 2 moderators on Friday from ACA.
a dedicated facilitator because we have 3
Yes.
panelist speakers. It will be
So I don't have,
time. Then I think one moderator could.
I don't need to moderate. I don't need to comment. There'll be 2 ACA. I don't need to do question and answer. Let them, and I will just read a proclamation.
Proclamation, yeah. That would be
Okay.
good. Yeah.
And let me tell you why also. I'm glad that this is working out well. Because on Friday, I have a church related event that starts at 7. So I'll be there at 6:30 to 7, switch to that, and then leave there early to come back to read the proclamation.
Okay, all right. Okay, that's
Just to let you know, because the last time I had this event, I couldn't attend because I had colonoscopy. So I
Okay.
can't skip this one.
Okay, all right, that's fine.
And there will be moderators, ACA.
Yeah, I want
Is
ACA and
ACA
I'll
is
back them
final?
up. But-
Do you got the final names who will moderate the event on Friday?
No, I do not. I will be talking to somebody tomorrow.
Because Karen said no,
Yeah.
Sudarshan can't make it.
Not-
Okay,
He might be able to make it some other day, but today he could not. I was asking him for today, actually.
okay. We need somebody for Saturday, Manju, because both of us are presenters, so we
I
cannot
know,
be the
yeah.
moderator.
We have to have moderator. And
For
that will be a
Saturday.
good one. Yeah, because it's mental health, self-care, that will be a good one.
Yeah, yeah.
We might get a lot of people from that,
And Manju, we need to plan a time to get together with Patch for a dry run. Are we using the exact same?
I'm going to look at it, Cora. It's such a long time ago.
I know. I need to look at it too.
Yeah,
When you
I
find it,
definitely-
can you send it to me? So
yeah, it's in a
because
folder. I know that.
if
Yeah.
you can send it to me, then we can
Okay,
make
all
changes
right.
together.
Okay, all right. Okay, now I have a question. What did we change in the evaluation form? Why were you guys talking about 1, 2, 3, and then Yasmin said which one is more important? What was all that about? Tell me.
No, I just stick with the original one, and I originally set up that the last 3 questions is optional. Yeah.
Because some may not want to fill it out, right? Is that the
Yeah.
concern? What is
So like
the best and what's the least? And then comments.
Yeah.
So that's optional now.
And I have a question that how will we give the incentive to the student participants, because I did not ask their email address in the evaluation form, and I think Christina suggests that I have to add another question to ask that if they are
If you're a
students,
student.
and their email as well.
Yeah. But if they register, then we should have their email.
But they registered. Okay, so you need to go back to the register rate form to search for their email. It's okay. Okay.
No, that would be more difficult. If you could just, or perhaps,
Ask them.
perhaps
Just ask them. Ask
in the
them.
chat, just ask them to let us know if they're a student, then we will.
So
Because I
I
know
just
there are
wanted
two
to add